Hi, everyone. Welcome to our workshop on the topic of how to be prepared for the 5 types of births. My name is Ananda, and I'm a member of the team at Boston Doula Circle. We provide birth doula and postpartum doula services and a variety of other offerings throughout the greater Boston area. I'm the co-author of the Doula Guide to Birth, published by Penguin Random House, and I was trained as a childbirth instructor under the auspices of the Lamaze International Organization, and I'm very happy to be here with you today. I am also going to ask my colleague Lauren to introduce herself.
Hi, very happy to be with you here today. My name is Lauren. I am also currently a member of Boston Doula Circle as a certified birth doula. I have supported many families in all kinds of different births, and myself, I had 2 home births for myself.
Great. So the way things will work today is that everyone who's watching live will be muted, except for myself and Lauren. And we'd like to invite you to put any questions or comments that you have into the chat box here on Zoom if you're with us live, and we'll answer those questions as we get the chance to do so. And those of you who are watching live can also help to answer one another's questions. And I'd like to say that today's class will be helpful for you if this is the only childbirth class that you take. And if you're taking other childbirth classes or workshops with us here at Boston Doula Circle, you'll be able to use today's information in conjunction with those other classes. So for today's class, we've organized the different ways that childbirth can unfold into 5 categories. And there are more than 5 types of births, but everyone has an experience that fits into one of these broad categories. And sometimes the type of birth that you have fits into a few of these categories, but at least one of them. And so we're going to be looking at the first type of birth is vaginal birth that is unmedicated. Number 2 is vaginal birth with an epidural. Number 3 is labor that starts on its own. Number 4 is labor that starts by medical induction. And number 5 is birth by cesarean section. And what's interesting about the 5 types of births is that they are not really interchangeable. For example, an unmedicated birth is not exactly the same as a birth with an epidural, with the only difference being that you feel all of the sensations in one birth, but not in the other. What we want to look at is that each type of birth has pretty specific and unique characteristics, and each type of birth has its own unique benefits and risks. And it's important to be informed about what these differences are so that you can maximize your chances of having the type of birth that you hope for. So let's look at what's unique about each type of birth. And we also want you to be prepared to respond in any birth scenario should you unexpectedly encounter a different scenario. And in that case, how can you still preserve what is most important to you? So that's what we're going to be looking at today. So we'll start with the first type of birth, which is vaginal birth that is unmedicated. And we're going to describe what this looks and feels like. And then we'll describe the potential benefits, the potential risks. And we'll do that with each of the 5 types of births. So for vaginal birth that's unmedicated, people generally describe the beginning of labor as they begin feeling sensations, but they're not painful. So if you're pregnant and watching this, and if you've been able to identify your Braxton Hicks contractions, that gives you a preview of part of the sensations that you'll feel when labor actually starts. It's the same biological function. And we all experience Braxton Hicks contractions, which can also be called warm-up or practice contractions. We all experience them starting in the first trimester of pregnancy, throughout the rest of pregnancy, but we don't hear people reporting that they can detect those sensations in the first trimester. Some people detect them in the second trimester. That was the case for me. At about the halfway point, 20 weeks, I started to feel my Braxton Hicks contractions, but it's also very common for people not to identify them until the last 1 to 2 weeks of pregnancy. So anywhere in there, if you've detected them, then that gives you a preview. There's a tightening of the uterus that happens. So when you feel that your pregnant belly and your abdomen feels as firm as a watermelon, that is a contraction. And a contraction simply means that a muscle is being shortened, that the two ends of a muscle are coming closer together. That gives us a contraction, and that gives us that firm sensation. So just like when I flex my arm, my bicep muscle, the two ends of my bicep muscle come closer together, and it's firm, and that's a contraction, and the uterus does exactly the same thing. Some people describe the sensations of labor as feeling like the cramps of a menstrual period, so kind of a muscle ache type of sensation in the belly. For anyone who's had a syndrome such as endometriosis, which carries some pelvic pain along with it, they would have a preview of some possible sensations of labor. And I once taught a childbirth class where an expectant father asked me if contractions felt like having a Charlie horse. And I thought that was a great description coming from this person who did not have a uterus. And that was his reference point. And I thought that was actually a good comparison. So a Charlie horse is, it's an involuntary contraction of a muscle. Oftentimes it happens in the leg, and it's more common during pregnancy. So if you're pregnant, you may have experienced some Charlie horses. I would say there's a little bit of a difference in the sensations of labor, because the contractions of labor progress or proceed in more of a wave. So they start out and have a buildup to a peak, and within that same contraction, the peak will start to recede and fade away. And a Charlie horse tends to come on more suddenly and to not go away very easily. So a labor contraction has a pattern, takes on a pattern that's more of a wave. And then one last thing I'd like to mention about possible sensations of labor, which you may or may not have heard about. A lot of people have not heard this, but sometimes people report having a sexual response in labor. And we don't really hear about that very often, but all the sexual and reproductive organs are involved in helping labor to progress. So the uterus is contracting, and sometimes people do have that experience. It might happen spontaneously, or it might happen because they are incorporating sexual activity into their labor as a comfort measure. So we've just dropped a link into the chat if you want to find out more about this. There's an article called "Can Women Orgasm During Labor?" And that was published on the Daily Beast website a number of years ago. That's an imprint of Newsweek, and it was they were reporting on a study which had just been released on this topic. So the point is to say that labor can encompass a really wide variety of sensations, and we want to be open to or acknowledge the possibility that there can be many types of sensations in labor, and that it's not something to be feared, although labor also means hard work. So there's a description of what happens in labor. This is a classic description that childbirth educators like myself often use, and that's to say that contractions become longer, stronger, and closer together as the hours of labor pass. So things intensify from that starting point, which feels mild. they take on a pattern and they start to come every few minutes in a predictable way with breaks in between. So as labor intensifies and you pass through the various phases of labor and the sensations intensify, eventually for most people, it will become the greatest physical and emotional experience that you will ever voluntarily undergo. So there's definitely a tremendous physical and emotional challenge to labor. And I like to start out my classes by saying, let's face the reality of that and let's embrace it, so that we admit and we know that we are getting into this tremendous journey. For some people, it's like climbing the biggest mountain of their life, or running a marathon, really a challenge that they've set for themselves. The other side to that is that you've got this amazing challenge that you're facing, and at the same time, you are equipped to do it. So if your goal or your interest is in potentially having a birth that's unmedicated, you can absolutely do it. And we believe in you 1000%. As long as the events of labor are going normally, we are all equipped to handle it. We're going on 300,000 years of Homo sapiens, and it's a very well designed system. And there are some exceptions when things fall outside of the range of normal, and we want to know what those are as well. So that because we wouldn't expect somebody to go through the experience at all costs. But again, when things are proceeding normally, you've got the ability to do it. And I'll quickly mention that if your goal is an unmedicated birth, your chances of achieving this inside of a hospital are most likely if you are able to utilize a doula. And simply as a side effect of having a doula present, the use of medical pain relief or medication is reduced by, we've got lots of studies, and the results show us anywhere from 25 to 60% reduction in the use of medication when a doula is present. We really don't have any other intervention available that gives us such a dramatic effect. So let's keep that in mind. You can find a doula in a variety of ways. There's one way is that there's an excellent website called doulamatch.net, and we've dropped that into the chat. And that's a nationwide service that's free that can help you locate a doula. And the last thing I'll say in terms of describing what unmedicated birth feels like, you've just gone through this very powerful challenge. And when your baby is born, something that's very interesting that happens is that the person's endorphin levels after giving birth are the highest that they will ever be at any time in your life. So they're about 30 times higher than endorphin levels in a non-pregnant person. Your body has really put out all of these wonderful chemicals to help you along the way. And once the baby's born, you're left with this extremely high level of endorphins. So sometimes people will report a sense of euphoria or a sense of feeling high after giving birth. So that's a bonus that can come with an unmedicated birth. And it's not the case when an epidural is used, because the epidural blocks the sensations of labor, but it also blocks the endorphin effect. So it's still a very great thrill to meet your baby, whether birth is medicated or unmedicated. But there is that bonus that some people describe of the endorphin rush, the euphoria after an unmedicated birth. So I'm going to hand it over to Lauren.
Yeah, so I'm just going to talk about some of the benefits or some of the reasons why a person might choose an unmedicated birth. in the case of an unmedicated birth, drugs and medications aren't being used. So there's no chance to get any side effects from any of the potential medications that could be used. Then as Ananda was saying, someone may choose an unmedicated birth because they want that sense of meeting this important challenge that they've set out for themselves, that they've physically and mentally prepared for to meet that challenge, similar to running a marathon, as Ananda said. Breastfeeding is more likely to be successful, according to the research, when your birth is unmedicated, when you have a vaginal unmedicated birth. It's also the type of birth that's least likely to lead to a cesarean section, although that's not guaranteed, the way that birth can unfold in different ways. Many people choose to go this route, this unmedicated route, because that's just what's expected in their culture. This is true for all the kinds of births we're going to talk about. A choice can be made because it is the norm in our particular culture or a particular subculture. And, when we talk about benefits or and those kinds of things, it's important to sort of talk about the other side too, any potential risks or side effects of this kind of birth. And, unmedicated birth, as Ananda was saying, we really believe is possible for the majority of people, but there are certain situations where it becomes truly not possible. And, sometimes if you were planning to have unmedicated birth and those, plans change, some people have reported, feeling pretty disappointed, deeply disappointed, or even traumatized, by having that outcome. And, this traumatic response may be more of a risk if someone has no preparation at all for unexpected scenarios. And that's why we're here today, to be more prepared for all the possibilities that can unfold, during childbirth. And also with any vaginal birth, there's also a possibility of strain or injury to the pelvic floor during pushing phase. This may be preventable with different pushing techniques, positions, and if this does occur, it's usually a very treatable thing.
Great, thank you, Lauren. So we've gotten a few questions in the chat. Feel free to add your questions there to the conversation. Someone asked whether, when I was talking about that endorphin effect, whether the medication known as Pitocin also blocks endorphins as well. And I believe the answer to that is no. We could double check that, but that was an interesting question that came up. And Epidural blocks responses of the nervous system. And the medication Pitocin does not act in that way. It stimulates a certain response in the brain. So I believe the answer is that the endorphin effect is a result of not using anesthesia, but it doesn't apply in the same way to the drug Pitocin. So the next type of birth, type of birth number 2 is vaginal birth with an epidural. And so I'd like to describe what that looks and feels like. So I described what contractions look and feel like without medication, and that's going to be the same experience until the point in labor where a person decides to request an epidural. And when an epidural is working correctly, 2 important things will happen. One is that the person will be free of the sensation of contractions. And number 2 is at the same time, they will be able to retain their motor ability. So they will actually still be able to have movement of their legs. So the abdomen and the upper thighs will have a feeling of numbness to them. However, that you still have the ability to consciously use your mind to move your legs around. And any epidural can be increased or decreased in its dosage. So we're here in the Boston area with many major hospitals, and we do not have a standardized baseline dosage for epidural anesthesia. So it's a bit different at every hospital in the area. Some hospitals use a low dosage as their standard baseline epidural, and some use a higher dosage. And with a higher or heavier dosage, the person will have less motor ability. So there have been studies showing us, and I'm thinking in particular of a study that came out of a hospital in Nice, France, which showed that even with a very low dosage, the pregnant women in this study reported very satisfactory pain relief. And at the same time, very low dosage, they retained the most motor ability. They were actually able to walk without stumbling or falling. And again, here in the US, in the Boston area where I am, hospitals generally don't permit people to walk with an epidural, but it has been studied and shown that it's possible because with a low dosage, you retain the most motor ability. So a doctor should be able to achieve both of those goals, completely satisfactory pain relief and completely satisfactory ability to retain motor ability and to retain movement. And we're going to talk about why movement is so important in labor. If someone were to feel that they could not move their legs in labor, that would indicate we've got quite a high dosage of the epidural, and you could request to have that adjusted. Again, any epidural can be adjusted or even replaced and started over again. Another element of birth with an epidural to be aware of is that here in the United States, hospitals do not permit people to eat solid food while they have an epidural. We may be the only country with such a strict ban on eating in labor. And this is not the case in other parts of the world, even when an epidural is used, but that is the tradition here. And so that could mean that someone has an epidural for a few hours and they're not eating during that time, or it could be a longer period of time. It could be an entire day, 24 hours or longer, where food is being withheld. So that's something that we want to be aware of. That is a pretty strict rule. And then the last thing I'll mention about birth with an epidural is that once you receive the epidural, you have the ability to go back to kind of normal everyday conversation, which was not really the case with an unmedicated birth, where all of the person's attention really gets focused on the sensations. So after receiving an epidural, somebody could have a conversation just like the one I'm having right now. And there are also there's equipment that has now become part of the process. So there's quite a lot of equipment. There's a pump which is delivering the epidural medication, and there are monitors which are tracking the response of the baby's heartbeat, and any effects that the medication may be having on the baby. There's also a monitor which is tracking the contractions themselves, and there is an IV being used in the person's arm to deliver fluid. So there's a fair amount of equipment being used, and what we've observed is that people may start paying more attention to the equipment. And these, in particular, the monitors, which beep, make noise, light up, have sounds, and they create they create an image of the pattern of the labor on a screen. So what we've observed is that sometimes the medical staff, as well as the person's loved ones and the pregnant person themselves, they might start paying more attention to this machinery than to the person in labor. So we want to be aware of that and turn our attention back to the person giving birth, the fact that this is the birth of your baby, and we can still incorporate labor support that we would use in an unmedicated birth. So we can still incorporate massage. You can still use meditation. You can say prayers if that's important to you. You can use positive affirmations, the same kinds of comfort techniques that we would use at any time in birth. We can still incorporate that into birth after an epidural has been used. Use all of the comfort measures that are available to you. And now I will turn it over to Lauren.
Thanks, Ananda. I think we should, I'm just gonna go over some of the questions in the chat quickly. And I'm gonna toss one to you because I know you have a lot of expertise in this. Someone asked what is in the epidural, and does the epidural pass to the baby? I don't know if you want to just briefly answer that question.
Yeah, sure I will. I'm just getting caught up and looking back at the chat. So the main ingredient in all epidurals is a medication called bupivacaine, and you'll find that all over the world and all over the country. Sometimes that is mixed with a few other medications such as fentanyl. And what you can do is there are different ways to create an epidural. So what you can do is right in the midst of labor, if you're requesting an epidural or considering an epidural, ask to speak and kind of have a mini consult on the spot with the anesthesiologist, the doctor who'd be performing the procedure, and just ask them, how do they create an epidural? And in particular, how would they create a light dosage versus a heavier dosage? And they have different ways of doing that. It could be a different mix of medications. It could be starting out with a lower dose to begin with than they normally would. It could mean delivering the medication more slowly through the drip that passes through a catheter into your epidural spinal area. So there's different ways to do that. And I think someone asks, another question was, can you request the amount of dosage you want? And yes and no. You can absolutely request a light epidural. So that's the phrasing that I would suggest using. And everyone will understand what that means. And because there's different ways to create that, we wouldn't necessarily say, go ask for a specific dose, but you can ask the doctor, how would you create a light epidural? And then does it pass to the baby? That's a good question. It depends on who you ask. Some people say no, some of the research, but some of the research has been interpreted to say that at least a bit of it passes to the baby. And we, as Lauren mentioned, it has been observed that with an epidural, that babies are more likely to, their behavior is more likely to appear disoriented after birth. And we can see an increase in babies not being able to easily latch on and breastfeed. That can usually be corrected over time, but we have observed that there sometimes seems to be an effect on the baby.
There's some other questions which I think you're going to address shortly about different positions for pushing, there was one, someone was asking about inserting a catheter, and yes, the answer is yes. Once you get the epidural, you'll either be put on a catheter continuously or they'll periodically empty your bladder. So that is the case for that. Someone asked about eating solid food earlier in the day during labor and then getting the epidural. I've observed that happens frequently, so I don't think there is generally an issue with that. And did I get everything here?
The last one asks, is there a time for getting an epidural? If you are past a certain point, can they not allow you to get it? And the answer to that is no. There used to be about a half a generation ago, and then the American College of OBGYNs and the National Anesthesiology Society issued a joint statement saying that they don't feel that there should be a time limit. So someone could request it very early in labor or very late in labor.
Yeah, and so, I'm just going to briefly touch on a couple of points about why someone might choose to get an epidural. Someone may choose this because they just prefer not to experience any potential pain associated with labor, and so they would choose the epidural. Some people choose an epidural for mental health reasons, such to, potentially manage their anxiety in labor. Though I will say, with support, people with anxiety are very capable of having unmedicated births. If labor is induced, which we'll talk about later, contractions are often stronger. You may experience them, more strongly than if you had gone into spontaneous labor or weren't using any augmentation. And so sometimes this can lead to an epidural as well. Though even if you do end up with induction, an unmedicated birth is still also very possible. Birth without the epidural, and people choose the epidural because it's just kind of the norm. It's just expected in their culture, similarly to the other choices that they might make about their labor and birth.
Great. So those were some of the benefits and reasons that people have said that they'd like to choose an epidural. And I'm also going to talk a bit about risks and possible side effects, and this will answer a question that came up in the chat. And I'll just start with the most common side effect is that pain relief is not entirely successful. So we've gone for the goal of eliminating sensation, and the procedure it's a blind procedure. So the medication is being inserted into a space in the spinal area that cannot actually be seen from the outside of the body. And it's not always possible to get it placed 100% correctly the first time. So we do sometimes see that a person has received an epidural, and over the course of several hours or even a bit longer than that, they need to kind of, contact their doctor several times to have things adjusted or possibly replaced altogether. So that's a possible side effect, is that it won't work properly the first time and it'll need to be adjusted a few times. Another possible side effect with epidural anesthesia is the possibility of a drop in blood pressure of the pregnant person. That happens in about 1 in 3 cases, that there's a drop in blood pressure. So that's why an IV is used to deliver extra fluid to the person at the same time, to put fluid into their bloodstream and try to prevent a problem with this drop in blood pressure. So about 1 out of 3 people. And for some of the babies of the people who experience a drop in blood pressure, there will also be a drop in blood flow to the baby. And this could result in what's called a non-reassuring fetal heart rate, also known as fetal distress. And this is usually treatable. So when we hear the term fetal distress, it does not sound so good. But it really means that there's the possibility that something might not be going well for the baby. It actually does not mean that we've confirmed that something is wrong with the baby. So the term that that has been suggested to be used instead is non-reassuring fetal heart rate, but it's interchangeable with the word fetal distress. And again, for everybody in the room who's had that experience, it can be stressful. However, it is usually very, very treatable. So there are techniques if a baby doesn't respond well, there are techniques. It's possible in a small percentage of the cases that a baby would not respond favorably to an epidural, and it could not be corrected, and then the baby would need to be delivered by cesarean section. Another possible side effect of an epidural is that labor progress can slow down for a couple of reasons. It might be that the muscles are over relaxed. And there's actually another reason I'm going to get to in just a moment. If labor slows down, then a doctor or midwife may recommend introducing the medication known as Pitocin to increase labor and to stimulate labor again if labor slows down. If Pitocin is used, this can also increase the chance of the non-reassuring fetal heart rate. So, and then there might be a few other risks or possible side effects that we can come up with, but I'm just going to mention one last possibility, which is that there does seem to be an increased chance of cesarean section when an epidural is used. And there have been different studies giving us different results on this topic. I'm referring to the Listening to Mothers study, which is a set of research projects that have been conducted at Boston University over the past 20 years. They've surveyed people nationally about the events of their births, and they've done this multiple times, and they've repeated the same results each time they've done their surveys. So on that note, we have certainly heard many pregnant people say that they plan to use an epidural. However, they will often express at the same time that they really prefer not to have a cesarean section. So what we need to do is look at the topic of cesarean prevention with an epidural, which is a very important topic, and it often does not get considered. And we really want to acknowledge that many people will choose an epidural, and many of the same folks will say they really don't want a cesarean. Well, how can we make that happen? We've got to talk about cesarean prevention and not leave that to chance. So the most common reason for a cesarean section is considered to be a diagnosis called labor dystocia. And the word dystocia simply means slow. So this has been the case for over a decade, and there's been a lot of conversation and debate about, should we be performing cesarean sections simply because someone's labor is slower than average? And there's a lot of critique of this topic, and many of us feel that we should be doing something to avoid a cesarean section in the case that labor is simply slow. So how does this relate to having an epidural? It relates in a few ways. After receiving an epidural, and this might be the most important link, there's an expectation that the person will remain lying down. So that, if you think about what you may have seen on television, that's the image I have. Person with epidural is laying horizontally in bed. However, lying down has several effects that we need to be aware of. One of them is that lying down makes contractions weaker, and therefore it slows down labor. So I'm going to give you a little bit more information about this. This is a paragraph that I'm going to read to you from my book, The Doula Guide to Birth. And this paragraph says, let gravity help. The strength of a contraction is rated in units known as millimeters of mercury. This is a way of measuring the amount of tension in the muscle. When resting between contractions, the tension in the uterus is less than 15 units. Contractions that are strong enough to dilate the cervix need to be 30 to 50 units above the uterus at rest. And the strength of contractions increases by 35 units simply by the mother being upright. So the strength that the uterus is able to put into the contraction is very much affected by whether a person is upright or lying down. So that's one thing that we want to keep in mind, and Lauren will drop a link into the chat if you'd like to hear more about what I have to say on that topic. I talk about it quite a lot in my book, The Doula Guide to Birth. So feel free to take a look at that. That was a little bit academic. Most of my book is not academic at all, but I know that paragraph was a little bit, but it just shows us how simple is this. All we have to do is get upright, and we can counteract one of the side effects. So other ways that an epidural might be associated with labor slowing down is that they are associated with an increase in babies remaining in a posterior position in labor. So that's when we hear somebody say that they had back labor, that's posterior labor. And that means that the baby's back is turned toward the mother's back or the pregnant person's back. And when babies stay in that position, they actually are not exactly in the ideal place to easily come through the pelvis. So these labors take longer, and they're more likely to result in a cesarean section. And then the last thing I'll mention about, again, slow labor. Number one reason for a cesarean is slow labor. And so with an epidural, the pushing phase of labor, the last phase of labor, last couple of hours, it has been documented to be longer when an epidural is used. And what's interesting that again, I'm here in the Boston area, and I know that pretty much all of the hospitals here do have a time frame or a time limit for the pushing phase. However, when we look at what the American College of OBGYNs has to say, and that's the kind of major authority in this country, they actually have said that there is no length of labor or length of the pushing phase that is too long in terms of having a poor effect on the baby. So it's more of a cultural issue that we've put a time limit on how long labor should take and how long the pushing phase should take. So let's return to the idea of lying down after an epidural. And even though lying down is expected, it's not required for any safety reasons. There's not a reason that somebody needs to be lying down. And lying down actually may not be a good idea for all of the reasons that we just discussed. So what can we do to counteract the possibly negative effects of lying down? And people had asked in the chat, the questions about motor ability and whether that effect on motor ability will impact someone's ability to push out the baby. The answer to that is possibly, but we can counteract that by using vertical positions. And this is not the norm, it's not the standard of care, but it's not a safety issue. So we really want to introduce or bring back vertical positions, which is how people give birth without an epidural. And we want to incorporate that into a birth with an epidural. So I'm going to show you what that can look like. Okay, so here's an image of a mother in labor who Lauren and I had the privilege to support very recently. She has an epidural. She's sitting 100% upright, and she's standing next to her partner, and he is standing 100% upright. So if you look at the two of them, they are both entirely vertical. She's not leaning back in the bed. This was accomplished by using a technique which is called breaking the bed. And a hospital bed can be adjusted in such a way where the feet of the bed are lowered. So you can see she's sitting in bed, and if the bed was not broken, her legs would be straight in front of her, but it's been broken down so that her feet can drop down, and the back of the bed is completely raised up. So she's 100% vertical. She's not leaning back at a 30-degree angle or 40-degree angle. She's entirely vertical. So that's an example. And I spoke to her, and she mentioned to me that the picture was taken, she thinks, after she'd had an epidural for about 12 hours. So to me, that's what I want to imagine when I think of somebody using an epidural. I want to think of entirely vertical positions rather than horizontal. Some of the times we lay down and rest, but we want to incorporate those active positions, because we do hypothesize and have observed many times that when we incorporate movement into labor, that's when we help the baby do its job of maneuvering the pelvis and coming out. And if we lay still, we may be hindering that process. So again, it's not the standard of care. So this means that folks have to advocate for it, but we've seen many positions. I've seen many people with an epidural get onto their hands and knees. I've seen many people with an epidural squat on their bed. These positions are possible. And in those cases, from what we've observed, it seems like those babies come out more easily. They don't get stuck as often. And so I also want to say you can use a doula to help you with this as well, because a doula is not just there to comfort somebody without an epidural and with the sensations that they're feeling, but really to advocate for you and to help you get into these positions. It still does take physical effort to change position, especially with an epidural. It takes physical effort, and a doula can advocate for this and assist you to do it. And then the last thing I'll mention about cesarean prevention with an epidural is a technique that is it goes by the name laboring down the baby. That's a clinical term. If you mentioned it to a doctor, midwife, or nurse, anyone would know what you're talking about. So the phrase is laboring down the baby. And what that refers to is that when a person's cervix has fully dilated, we've gone through most of labor, we've arrived at the second stage, and we're soon going to be birthing or pushing out the baby. Some of our healthcare providers, doctors and midwives, have been trained to tell the pregnant person to start pushing simply because the cervix is dilated. However, for some babies, this is going to work. And for other babies, they are not actually quite ready for the pushing phase. The baby needs to rotate their head. They're already head down, but they need to rotate the head position to be lined up to fit through the pelvis. So a baby's skull is an oval shape. And I'll try to turn it this way. It's an oval shape. I'm not making the best oval here, but it's an oval shape from top to bottom. I'm sorry, from front to back is an oval shape. The pelvis is also an oval shape from side to side. So we need to fit the oval shape of the baby's head into the oval of the pelvis. And babies need time to finish that rotation. If they haven't finished, then we've got one oval trying to fit through another oval, and they're not lined up, and that's when babies get stuck. So laboring down the baby just refers to incorporating a waiting period. That once someone's cervix is fully dilated, rather than saying, go ahead and push now, we actually want to incorporate a waiting period. And for some babies, it might be 1 hour for the baby to finish rotating. For another baby, it might be 5 hours. Once the baby has rotated, it's going to come through fairly quickly, probably in less than an hour. And we don't want to spend out 5 hours pushing with one oval against the other not being in alignment. So laboring down the baby has been studied, and it's been proven to be a cesarean prevention technique. So now we will go on to the type of birth number 3. And I'm also going to take a look at questions in the chat and see if there's anything that I need to help with there.
Yeah, there's a couple questions about what upright positions are, but I think we went over that and I briefly answered that. Another question was about the combination of epidural and Pitocin, and do they counterbalance each other? And just to briefly say that, your Pitocin is going to be sort of adjusted throughout the labor. If you are using Pitocin, your providers are going to be looking for a specific contraction pattern. So they'll be, balancing that also by looking at fetal heart rate and how baby is reacting to that. So all of that will be sort of evaluated together. I wouldn't necessarily say they like cancel each other out in that way that it seems like you're asking. And Don, did you want to keep going in the chat and I'll start on the next topic? Okay, great. All right, so the next type of labor that we're going to talk about is labor that starts spontaneously or start on its own. And so what this looks like or feels like, you're likely to be in your own home when labor starts. And if early labor is long, sort of that early labor that's not particularly painful, that Ananda was describing at the beginning, people will sort of go about their normal day. You may visit friends, go out to dinner. Some people like to have an early labor project that sort of keeps them busy during this time. And since you're at your house, you'll have freedom of movement to do any kind of positions or movement that you want. You want medical equipment attached to you. You can walk around your house, go outside. All of those are options as you feel comfortable. And it's normal, in the case of spontaneous labor, for the progress of labor to ebb and flow. You may experience some plateaus where your labor sort of stays the same for a little bit, which allows you to sleep for a few hours. And sleep is absolutely possible in labor, and something that we encourage. And so why might you choose to go into labor spontaneously? There's no medical emergency to get labor going or induce labor. And so you wouldn't need to start labor, if you're having a normal pregnancy, no medical conditions, there wouldn't be a reason to start labor by medical means. And in some other cases, a provider may suggest an induction for non-emergency conditions. And some families choose to decline, an induction in this case, if there's not research or evidence showing that it would improve outcomes. One example of this is something called suspected large baby, where if you've had a third trimester ultrasound, they might look at the ultrasound. And, there's lots of research studies out there that show, that provide evidence or not to how this may improve outcomes by moving forward with an induction. Normally, labor is started by the baby. The baby sends out hormones to the mother when the baby's lungs and organ systems are developed to the optimal point for life on the outside. And spontaneous labor, supports this natural process. Spontaneous labor is also less likely to lead to cesarean. And, just as some of the other reasons why we might choose this birth is because it's just what's the norm, it's just what's expected in your culture. And I think Ananda now is going to talk about possible side effects of labor starting on its own.
So in case of a medical emergency, if we don't make use of an induction, this might result in a poor outcome for the pregnant person or the baby. And so what I am using as examples of a medical emergency would be certain instances of preeclampsia, when the pregnant person has a condition of extreme high blood pressure, or a situation known as a placental abruption, when the placenta starts to come away from the side of the uterus. And those are cases where we know that the cure for those conditions is to deliver the baby. We have research and medical evidence showing us that will cure these emergency situations. And if we were to not make use of an induction, we might find ourselves with those poor outcomes in those emergencies. And even if there is no emergency, so I'm going to talk about another kind of, I'll put it in the category of risk of spontaneous labor that starts on its own. Even if there's no emergency, there can actually be a great pressure to induce labor. So that induction of labor has become, has increased to numbers that are quite high. And we'll talk about that in our next section, which is labor that starts with medical induction. So even if there's not an emergency, if someone decides to decline an induction, that can feel stressful and they might feel isolated if they don't know anyone who has declined an induction. So there's no medical emergency, but having to make that decision, we've observed, can be stressful for people. So I will now go on to type of birth number 4, which is artificial induction of labor. And in terms of what that looks and feels like is that the pregnant person will start labor in the hospital. They'll be given some type of medication, and it could be one of the following or a combination. It could be an oral medication or a medication that's placed into their vagina, such as misoprostol. It could be delivered through an IV into their bloodstream, and that would be the medication Pitocin. They might be offered a medical device that's placed inside of their cervix to mechanically open it, and that's called a Foley catheter. So those are the ways in which labor, we can attempt to start labor by medical means. And just like spontaneous labor, the early phase may be long during an induction, and it can be a multi-day process. So it's good to plan ahead with lots of ways to pass the time. So you, a person in this situation would probably benefit from bringing things with them, such as your movie watch list, books and magazines, board games. Sometimes we've known people who've in the hospital, they've brought in a massage therapist or an acupuncturist, somebody to give them a comforting treatment that may also help boost the effects of the induction. So think ahead about ways to pass the time, because there could be, 24 to 48 hours spent in one room before we start to see the induction progressing toward more active labor. Once we've reached an active labor phase where contractions are being felt and they have built up to a stronger intensity, then we do hear that people report that those contractions can often feel even stronger than natural labor. Contractions that are brought on by an induction. So there may be an increased need to use pain medications, although an unmedicated birth may still be possible. And one thing I'd really love to share with you is that we've had a number of studies come out in the last decade, which looked at what to do if we get to the point where the contractions that are brought about by an induction become very strong, overly strong, they become too difficult to tolerate. And what these studies have looked at is that there is the option, if Pitocin is being delivered to the person through an IV, there is the option of turning off the medication, turning off the Pitocin. And all of the studies that have been done on this have found the same thing. They were looking to see if Pitocin was to be delivered, they would compare one group of people who received the usual standard of care, and that's when the medication continues to be delivered for the entire labor until the baby is born. But then they compared that with a second group who received Pitocin only until their labor pattern became active, and they were feeling contractions probably every 3 to 5 minutes apart. And they turned off the Pitocin at that point, active labor for that group. And what they were looking to see was, would the induction succeed or would it fail? And a failed induction would mean that labor would stop and they would have to perform a cesarean section in order to birth the baby. What they found was that labor did not stop, and that the person's hormonal feedback loop and their brain took over and kept the contractions going. So I have witnessed this numerous times, and as a doula, my role has often been to support the family and then go locate someone on the medical staff to say, this person's reporting that labor is getting overwhelming. They're not feeling a break in between contractions. Would it be possible to turn off the Pitocin? And because that's not the standard of care, the answer usually is, oh, that's not really how we do things. We keep it running. But the family can advocate for themselves and say, we would like to try that approach. There is no harm to turning off this medication, which has a very short half-life. It can always be turned back on. And so in the instances where I've witnessed this, the person's labor has always continued. It may drop down a notch so that if they were about to, request other medical assistance or pain medication, they actually didn't need to, and labor kept going. So the worry was, would labor stop? And therefore the only other way to deliver the baby would be a cesarean. The answer was no. And what they found was that the cesarean rate was actually higher in the group that received standard treatment, and the Pitocin continued to be delivered. So I'm sure that there were exceptions to this. I'm sure that there were some people in the stopping Pitocin group whose labor did slow down, and then they would maybe restart it and then stop it again at a later time when things had progressed further. But what they found overall was that it was successful, and this study has been repeated multiple times in the past decade. And Lauren has dropped a link into the chat if you'd like to read more about that research. And Lauren.
Sorry, I was just answering a question in the chat. Okay, so to talk about why someone might choose an induction of labor, one of the reasons is that there may actually be a medical emergency, such as preeclampsia or placental abruption. And the research shows that delivering the baby in these circumstances will cure these medical conditions. Some people also report that planning the date of their labor gives them a sense of control. I think the important thing to just keep in mind there is that, with the induction of labor, you can also lose some control, or some control can be removed from you if there are side effects to the particular induction. And, for some cultures, this is just the norm. So that might be another reason why someone chooses to move forward with the induction of labor, artificial induction of labor. There are some side effects and some risks, just as we sort of talked about, in normal labor, how the baby sends out hormones that drives spontaneous labor. In the case of artificial induction, a baby's lungs may not have reached maturity for life outside, and it's possible that baby may need medical assistance after birth. So, as Ananda mentioned as well, the induction medications can occasionally lead to those non-reassuring heart rates in baby as well. Labor can get overstimulated by the medication, and there is a rare possibility of a ruptured uterus in this circumstance. And, also with the artificial induction of labor, there is an increased chance of cesarean section.
Okay, so we know that many people have inquired with us and inquired with other people that they know about whether there are non-medical ways to induce labor. And there are a few techniques that have been studied and shown to be possibly effective. One of the techniques is something known as nipple stimulation. So it's been observed all over the world that if you stimulate the nipples of a pregnant person, this often results in contractions. And we'll include a link in our chat to a podcast about the research on nipple stimulation. And this link comes from the website Evidence-Based Birth. You can listen to the podcast, or you can click on the transcript. And this is a source that we feel to be reputable, and she's reviewed the research on the topic of nipple stimulation. And the other thing I'd like to say about induction of labor is that it's currently at its highest rate in history. So 40 to 50% of births are being reported as induced in the United States. And that means that many people will find themselves in a position of needing to decide whether to go forward with these procedures, because they have become very, very common. And if someone is not facing a medical emergency, we hope it's helpful to remind you that there's more than a 99% chance of having a live and healthy baby, whichever decision that you make, spontaneous labor or induction of labor. There's a small chance of a risk with either choice, and we can't know exactly when that's going to happen. So our wish is that we wish we could take away the pressure that so many families have come to feel about this topic. It does, we feel that it puts parents in a position of needing to make a decision that can feel quite difficult. But the chances of a positive outcome are extremely high, regardless of which decision that you make. So that's a message that we wanted to pass on. And so now we will go to the type of birth number 5, which is birth by cesarean section. And what I'll say about cesarean birth is that it may be hard to imagine yourself in this situation if it's not your plan. However, any of us might give birth by cesarean section. And for that reason, we encourage everyone to become informed about it. And being informed may help you with cesarean prevention. So we want people to be willing to look at the information, or if someone were to unexpectedly find themselves in this scenario, it will help them to be prepared if they've become informed ahead of time. And becoming informed will not cause a cesarean to happen. So we hear stories of people who say that they were reading their pregnancy book and they skipped the section about cesareans. Because that was not the type of birth they were planning to have, but we instead take the view that it's actually helpful to be informed. So one resource that can be helpful is a book called The Mayo Clinic Guide to a Healthy Pregnancy, and that book has a chapter on cesarean section, which is written in a neutral way, and it gives you a more detailed description of the surgery. And I'm going to give you a basic description of it. So what it looks and feels like is that first we can think about the environment of an operating room. So an operating room it's well lit, brightly lit, so that the doctors can see what they're doing. And the air temperature is fairly cold. And the operating room looks and feels sterile because it literally needs to be sterile for safety and infection control. So it's a sterile looking environment because it has to be. So we, one kind of small thing that the pregnant person could do to personalize the environment more if they were to have a cesarean section is just like during vaginal birth, they might use music for relaxation. They could bring their own music with them into the operating room, and again, to kind of personalize the space and also to use it for relaxation purposes. Usually the partner or a support person is also allowed to be present. And at the beginning or right before the procedure, there's a preparation time that where the medical staff is getting organized. And that preparation time can take about 15 to 20 minutes. And after that, the time that it takes to deliver the baby, to begin the operation and deliver the baby, that is short. That period of time is short. That takes approximately 10 minutes. So once the surgery is begun, it takes about 10 minutes for the baby to be born. After the baby's born, a longer period of time will be needed to stitch the layers of the uterus and the abdomen. And that part of the procedure takes about another hour. So the birth of the baby happens quickly, and then the repair is what takes a longer a longer period of time. So once the baby's born, they will be examined by nurses and possibly doctors on a warming table in the room. And if the baby is stable and in good health, then a nurse will bring the baby to the parents. And that's a very basic description of what happens. And for more information, we also recommend watching a short video that's 12 minutes long. It's called The Natural Cesarean. And this video was filmed in a hospital in the UK, which began using a new approach to cesarean section. The surgical approach is similar to what's always been done, but they incorporated some other elements, and it's now more likely to be, this approach is more likely to be called a family-centered cesarean. Here in the Boston area, this is becoming closer to the standard of care, which is really interesting, but it depends on what part of the country you're in as to whether your hospital is very familiar with this. So the video, we've just dropped a link for it into the chat, and it briefly shows a baby being born by cesarean. And the main difference between the older approach to a cesarean and this newer approach is that the baby is kept in the operating room with the parents rather than a nurse taking the baby out of the room to a nursery. So up until recently, even if the baby was deemed perfectly healthy and stable, the standard of care was actually to remove the baby from the room. But in the family-centered cesarean, the main difference is to keep the family together, and most people would probably feel that this would be important to them. So you can definitely speak with your care provider prenatally and ask in case of a cesarean section. If you'd like to request that your baby be kept with you, that's certainly a conversation you can have. It's an absolutely reasonable request. In some regions, it has become the standard, and in other places, it might not yet be. But take a look at that video. And then Lauren.
Yes. So what are some of the reasons a person might choose to have a cesarean? Just there might be a medical emergency such as preeclampsia or placental abruption where this emergent, this cesarean may be medically necessary. There may also be a situation where the baby cannot, be delivered another way. For example, if the baby's shoulder is trying to come out first, or there's a different position of the baby, which makes vaginal birth not possible. And, some people choose a cesarean in cases when there isn't an emergency, in the case of labor dystocia, where labor is slowed or slow, this is where your provider may start talking to you about their preference, coming, about cesarean section, and your provider may not be giving you other options. They may not give the family other options. And so, unfortunately, sometimes in these cases, the families do report that they feel pressure into accepting the surgery. And lastly, in some cultures, this cesarean section is actually the norm. In Brazil, I think rates are 55 to 84% of all births are delivered by cesarean section. So someone may just choose it simply for that reason.
Okay, so we can also look at risks and side effects, and somebody had questions in the chat about VBAC, which is vaginal birth after cesarean, and we may not have time today, I'm sorry, to go deeply into that. I'm going to suggest looking at a resource called Childbirth Connection, and that is a reputable website that has studied and reported on factors in childbirth also for the last several decades. Lots of research is reviewed there, and they have a great section on a great part of their website on cesareans and vaginal birth after cesarean. Great. The questions I see are really excellent, so I'm sorry that I'm not able to answer them. And then someone asks about thoughts on breech births. Why aren't doctors trained for birthing breech babies? In Canada, the National Obstetricians Association has voted to kind of reverse their approach, which was to deliver breech babies by cesarean section, and the United States has not caught up to that yet. And the website was Childbirth Connection that I mentioned, and that has been put into our chat, childbirthconnection.org. So we are probably going to go over time by about 5 minutes, and I apologize for that. We're almost finished. I wanted to cover a few possible risks or side effects of cesarean section. One that's a common side effect is that there's a greater risk of infection. So that could be infection of the uterus or infection of the scar area. And then something that's not so common, but is a possible side effect, is that there can be an increased risk of hemorrhage or heavy blood loss. Again, not so common, but the risk is a bit elevated with cesarean section. For future pregnancies, there is an increased risk for future pregnancies. So the placenta in a future pregnancy might become abnormally implanted into the uterus. And again, this is another one that's uncommon, but does increase, the risk does increase with cesarean section. And then when we think about recovery after the birth, recovering from surgery is often described as feeling more difficult than recovering from a vaginal birth during the postpartum period. The physical recovery seems to be more difficult. And then with any surgery, there is a risk of depression after the procedure, and doctors don't usually remind people who are having a cesarean that that's a potential side effect, just like it would be with any surgery. There's an increased risk of depression. And so another resource I want to recommend is an article on cesarean recovery by a woman named Diana Snyder. And Diana is a wonderful doula who recently moved away from the Boston area. She's also an attorney who's had an incredible career, and she's become an advocate for childbirth issues. And she wrote an article called Tips for Cesarean Recovery. And there's a lot that you can learn about how to make this more complicated type of recovery into a gentler and more positive experience. And there are things we can do to help prevent this increased chance of postpartum depression. And Diana Snyder's article has done an amazing job of covering this topic of recovery. So whether or not a cesarean is your plan, we recommend that everyone read this article in advance so that if you needed the information later, you would possess it and you'd know where to go back to find it. So highly, highly recommend thinking in advance. If someone were to have if someone's birth were to include unexpected elements, how could you then activate the support that's needed after a more challenging experience? And if we think about this a bit ahead of time, what's my plan B? Maybe I've asked my family to come visit a week or two after the baby's born under regular circumstances, but in case of the unexpected, I may need help the day that I get home. And what arrangements would my support people need to make in their lives to be there for me as soon as I needed it? So we want to have a plan B, and that article will give you almost all the information you need. It's an outstanding article. So we're going to finish up now, and we're going to just want to give you the message that whatever type of birth you're hoping for and whatever type of birth you experience, we encourage you to do a few things. Number one is to become as informed as you can be. And for those of you who are watching us live, you can save the chat here on Zoom with all of the web links and all of the books that were mentioned in class. And you do that by going to the chat, and on the far right, you'll see 3 little dots. You click on that, and then you click Save Chat. And we hope you'll explore those resources more thoroughly. So, do what you can to really be informed and educated. Number 2, talk to your doctor or your midwife about their approach to helping you have the type of birth that you're seeking. So if you're seeking an unmedicated birth, what is their approach? to unmedicated birth. How would they help you achieve that? If you're seeking birth with an epidural, but your wish is to avoid a cesarean, how would they go about incorporating cesarean prevention methods into their approach? So have these conversations with your healthcare providers. And then number three, as doulas, we believe in bringing an advocate with you when you give birth. So whether that is a doula or a friend or a relative besides yourselves. So even whether you're partnered or single, we'd love to see you have somebody with you besides yourselves who can act as an advocate. They don't have to be professionally trained as a doula. That does help, but if it's someone that you trust and you feel confident that they know how to be a good support person for you, they can just be there to help you at decision-making points. And all they have to do is ask you questions like, you know, how do you feel about going, you know, choice A versus choice B? Do you want more information? And, you know, what are the risks and benefits to this to the scenario that we are talking about? So we really encourage you to have that support person with you while you are going through this tremendous physical and emotional experience of welcoming your baby into the world. Let's have another person there for support as well. So we're going to pause right here, and I'm going to stay on the line, but I'm going to pause the recording and we'll finish our program right now.